We're going to get started for session 3, panel discussion on overcoming the challenges with remote care models. So I'm going to ask our 3 panelists to come up and grab a couch. All right, so Dr. Roxana Dronca is coming back for round 2 to help us learn more about her perspective from Mayo. Dr. Michael McGillion is an associate professor from McMaster University, holds the Heart and Stroke Foundation and Michael G. DeGrood Endowed Chair for Cardiovascular Nursing Research at Mac. He's also an assistant dean of research in the School of Nursing and a scientist of Population Health Research Institute at Hamilton Health Sciences. We're going to be hearing a lot about his work in remote automated monitoring for people recovering from surgery. And then last but not least, we have Jenny Catton, who most of you know. She's a clinical director here at Princess Margaret with over a decade of experience in healthcare leadership, and she's played a pivotal role in designing and implementing virtual care and other big projects like e-referral across many stakeholder groups. So yeah, excited for this. All right, so we've got a bunch of questions, and I obviously draw from your experience at your different organizations to help fill this out. We've heard a lot of great, different models of care from different people across the morning. And today, to start, I want to start with the patient experience. How do we make sure that all these great, promising models of care are actually designed and deployed from a really patient-centered perspective?
You can just flip the switch. Here we go. Thank you. So I'll start with this one. I think the concept of patient co-design, it cannot be underestimated. But the nuance, because I think that that's something everyone's like, yeah, patient co-design, is using a variety of different patient engagement strategies and recognizing that we have a highly diverse patient population. And so things like surveys are going to get one patient voice, focus groups are going to get another. But in more systemically underserved or vulnerable populations, you really have to go more above and beyond in those patient engagement strategies. At UHN, we have an organization-wide virtual care strategy, and to support that, we went and did a process called peer-led focus groups. And so it was working with community-based partners, and they were the ones that reached out to these vulnerable populations and asked them their perspectives of virtual care and what is it that you need to feel confident and to feel safe in a virtual setting. And it's through those conversations that you get the innovative ideas of, yes, there's some patients that they're never really going to feel comfortable with virtual care, but there's others where if you base a virtual care pod in a community center with a peer mentor beside them, suddenly a technology that was not accessible to that patient is suddenly accessible to them. And so having a variety of patient engagement tools, I think, is really key for us.
I would fully agree. We're using all of these. So we had focus group, we had questionnaires, and on most of the grants, we have actually a community scientist or a citizen scientist that sits on those. We really use patient feedback from our pilot to then improve the system, and we continue to use that, and we're tracking every reason for patients not wanting to participate in clinical trial. So we kind of understand what are some pros and cons. I'll give you just an example. In the pilot and in one of the focus groups, we heard that patients really want to keep their home and cancer lives separate. They don't want in the living room to be the tablet and the devices that then everybody can see that they are being treated, they have cancer, or to remind them. So we actually devised a collapsible box that has the tablet and all those, that the box becomes really small and the patients can put it in a drawer. So listening from the patients helped us making things better.
It's a great question. Can you hear me? Okay. That's a great question, Mike. And we've actually, in our program, had similar feedback about people wanting the ability to put it away when we're not connecting. I think the responses here are terrific. I think largely in our program in surgical transitions, trying to ease transitions from hospital to home, and that's inclusive of our surgical oncology patients, it is really understanding the journey deeply. And so one of the techniques we have used a lot in our program design and redesign, as we reiterate, is patient journey mapping. And so to sit down, we have dedicated partners from the community who take us through guided conversations about their journey, what's gone well in their transitions care, what has not gone well at all, and what are our specific targets to fix it, and being curious around that, and then revisiting that on a regular basis to see how are we doing in terms of design. I think the other sort of larger comment is keeping things patient and family centered is a commitment to simplicity on the patient and family end and the complexity on our end in the back. And so easing workflow, easing burden in terms of how laborious is the process, keeping that to a minimum, I think is an important concept.
Now, so both of you mentioned use of biometric devices and setting them up into nice little packages. So it's great that you guys are using biometrics. We have some programs going as well with biometrics. From my perspective, it feels like biometrics there's a lot of hype around biometrics and wearables back in the day. And I feel like it maybe hasn't fully reached its potential. What are your experiences, and how have biometrics been used, and what are the challenges that we need to overcome to kind of reach the full potential of that in these remote care models?
Okay. Well, thanks, Mike. It's a big question, and I think there's a few things in terms of clinical utility of continuous biometric devices. And so I think one is understanding, first of all, what is it for? And so do you have clear targets? What is the information you need? And how are you going to digest it? And so for us, we really, because we're concerned about really catching early the big killers after surgery, for example, myocardial injury, sepsis, examples of those things, we need to really be focused on what are the signals that we're trying to curate well, how do I digest high volumes of information efficiently, and how do we have clear thresholds for decision making. So I think the biometric monitors are the monitors. I think it's the people and process in place to digest the information efficiently and to be able to negotiate information density in the command center you design. And so how do you display the information in a way that your clinical team can use it and be highly responsive to it in a standardized manner? To give you an example, in one of our earlier trials, we were asked to sort of spread our effort at various centers across Canada during the pandemic to help with safety and reduce readmissions and so on after major urgent, emergent, semi-urgent surgeries. And so one of the things we did well at our center, because we had a bit more maturity, was we were conservative and quite standardized about thresholds for escalation from nurse to physician, and the time required to respond in a timely manner to that type of data. Other centers were newer to it, and it was a big learning curve, and so we allowed them to relax the thresholds in some indications. And what did we find? The intervention effect just diluted it totally. And so I think it's really about being very thoughtful, and at times with biometric data, knowing what is the sweet spot between being too conservative, like how to manage that noise to signal ratio, I think is really key. Also, these devices have to be unobtrusive in patients' lives at home and not a nuisance for it to be successful.
Yeah, I would just amplify that. We've learned exactly the same thing. And for outpatient cancer care, you really don't need continuous monitoring. And now that we've treated a variety of patients with a variety of regimens, we know that not everybody needs it. So we're going to scale it back. Prostate cancer patients receiving Lupron, they do not need to have any type of remote monitoring at home beyond the ability to connect to the care team. Cisplatin, etoposide, a more complex chemotherapy regimen, you need to have the ability to do intermittent vital signs when the nurse guides them. We're getting ready to administer some bispecifics, in the home after maybe the first couple of treatments when there is a higher rate of, cytokine release syndrome, then move it into the home. Maybe those patients need to have more continuous monitoring. So really adapting the need of monitoring and the way you monitor to the intensity of the treatment that you're giving, at least for the outpatient oncology.
Yeah. Another factor of the biometric monitoring is the actual inventory management, and I think that we underestimate that. In order to allow a patient to have biometric monitoring, you have to provide them a weight scale, a blood cuff, they have to take their temperature. And it suddenly pushes hospitals into a situation where you have to become a courier, you have to have physical space to house 500 blood pressure cuffs. And that isn't really our typical business. We're not experts at that. And so I do think that at face value, we look at a business case, you think, okay, I would love to be able to put this off to a vendor, but my gosh, that looks really expensive. So, okay, I'm gonna kind of cobble it together. And I think what ends up happening is that we're not thinking about the opportunity costs of doing it ourselves. And so Michael had shared a very humorous story where Canada Post went on strike. And so it comes Christmas time, and Michael is physically driving around himself, bless him, to deliver these types of devices to patients because there was no other option. That's a pretty huge opportunity cost to have a director driving around Christmas time. And so don't just look at the cost of, okay, you need an administrator to be able to managing the inventory. You also need space. That's an opportunity cost of could that actually be used for clinical care. You need time. So just to look at the full cost, not just the dollars and cents when thinking about inventory.
My retirement job is I'm going to be a delivery, and I'm a terrible driver, so it's just bad. It's bad for everybody over the Christmas holidays, but it's true. We were caught off guard because I did not anticipate how backlogged FedEx was, and we deal with courier failure all the time. And we've tried to hand inventory management over to a third-party vendor. It's expensive. Finding the right formula for it being time sensitive enough is a challenge, so we do it ourselves as well. I will say I couldn't agree more. I pride myself on the virtual care environment that we've built that's fairly state-of-the-art. One thing I did wrong is the space for the inventory management and processing is far too small. And it causes problems, yeah.
Nice. A common concern or issue with remote patient monitoring and remote care is, especially when biometrics are involved, or the perception is that there's going to be a ton of data coming in, and what do we do with it all, and how do we process it, make sense of it, not overwhelm the clinicians, alert fatigue, while providing insight into the patients at home. How do we deal with that?
We have the least amount of data, so because we're doing the intermittent, data collection, and I think we're having the nurses, are the ones who are actually handling this data, and then they have algorithms where they need to intervene or not, depending on vital signs, et cetera, or the day of the treatment. For the hospital at home program that Mayo has, where you have more continuous data, then yes, you do have to have an ability to filter, what data comes in and how do you digest it, how do you respond to it, the algorithm. So you really have to have both kind of an algorithm built into it, but then also a human at least at the other end to be able to triage, some of this. So that is why initially when we started Cancer Care Beyond Walls, we met with the company and they said, well, we can give you a bio button that you just put it, here and it will collect continuously temperature, and you're gonna know at all times how the cancer patient does, if they have a fever. And we were so excited, and then we stopped after 5 minutes, and I'm like, but do I want to? No, at all times, how somebody's temperature goes from 96.4 to 97.5, and then how do you deal with that? Do we do that today? If we treat patients in the chemotherapy unit and then I see them in 2 weeks? No. So I think you have to really think about what you want, because you can get the moon and the stars, but what do you do with it?
I absolutely agree, and I think we're still early in the science of using high volume biometric data well, and so I think to be clinically effective, we have to employ the best practices that we know of now, clear thresholds, conservative enough that you're not concerned about missing something, having the right people in place. We have a study that we're undertaking soon called Vision 2, where we're applying continuous biometric monitoring, multiple channels, including continuous non-invasive blood pressure to 20,000 patients. Really looking at deep learning architectures to help us understand what information can we glean from the underlying waveforms that we are unaware of now. So I think there's so much more to learn. So I think in the way we do it now is still quite crude.
I agree with the statement that we're really at the beginning of this, and I think we have to be respectful of that in our implementations. And part of your brain wants to say, these are clinicians, they're used to seeing this data, they'll figure it out. But I do think that we have to respect that this is a huge new amount of data that they're not used to, and actually spend the time in these more early implementations creating the algorithms, giving a little bit more guidance of what is data you have to act on and what is data you don't. Many of you in this room are clinicians and care providers, and your number one gut reaction is, I have to help this patient, I have to do something with this information. And so it's actually a huge lesson to learn of sometimes you don't have to do something with that information. And I think that's what we have to battle. And so being incredibly critical about what data we actually bring in is a way to help that. And then also kind of processizing it, which is a bit of an upfront investment, but I think worth it given how immature we are in this area.
And I would just add, too, that there is a patient safety as well, because if you collect the data and then you have a data that you don't act on, you give the patient a false sense of relief in a way that you're going to handle that data. You remove because patients now know if they don't feel well, or they have a fever, to reach out. But if you collect and they think that at the other end, somebody will look and react, they won't necessarily potentially bring that symptom to your attention. You miss, that particular set of data, and you don't act on something that could be potentially be life-threatening for a patient. So I think that's another aspect that we really thought very careful about.
Another common concern for some patients and some patient populations is around, just the general idea with any virtual care is losing that in-person connection, that face-to-face, that human connection with their provider and their care team. What do you guys think? Is that accurate, or are there techniques or strategies that you've employed to kind of overcome that?
For us, that was probably one of the number one concern from our patients, that they will lose that, human connection. And fast forward 6 months into our pilot, what we heard from the patients is that they really got to be very comfortable and good friends with our chemo nurses who were online. It's a handful of nurses, so we tried to keep consistency with the virtual team that was taking care of the patients. And also, we try to be consistent with the home health nurses that visited specific patients. And I think as you scale up a program like that, that will remain the case, because you want to have geographies that are concentrated on kind of where those home health nurses operate, so they don't have to drive, too much. So they actually got to be quite comfortable with that team, both in the home and virtual. And then again, we maintained the visits, like every 3 months, we maintained the visits in the clinic with the care team to be able to see scans and, do prolonged visits. So at the end, when we checked with the patient, that ended up not being a big aspect at all. Limited data on 10 patients. We are actually now collecting data on our clinical trials, and I'm really curious to see if that will stay the same.
I think too, as we're focusing on more proactive models, that virtual care really allows us, that it's actually increasing trust that patients have in us. I mean, I think we heard that in the prior discussion around Watchman, and I think Nicholas, I don't know where you are, even said that virtual care really allows us to build stronger relationships with our patients. Like, the reality is our patients are coming into clinic. Sometimes they're not even seeing their primary physician, they're seeing a learner. And you hear this commentary of the in-person experience of, I just feel a little forgotten sometimes. And virtual care allows us to provide those additional supports and automated communication out to the patient that will ultimately help us build that trust.
I agree with all of these comments, absolutely. I think it depends on design. And so, and thoughtfulness that needs to be put in place about the proactive versus reactive aspects of your model. And so, to give an example, in our program, we started, nearly a decade ago, literally in a closet on a cardiac surgery ward, trying to do something, and doing video visits with patients every day for the first 30 days because I was concerned, we would miss something, right? And then you gain maturity. Now our model has a pre-scheduled video visit with nurse and physician together on day 1, a check-in on day 3, day 7 to optimize medication for long-term health management, day 14. Across days, data is coming in, and we have an ad hoc visit as needed. So with the right balance of proactive and reactive, we see consistently that we know our patients way better than before. There's more rapport, we get to know them. We have surveyed asking for the good, the bad, and the ugly. And in terms of patient and family experience, there's been very little, it's very extremely positive. They feel engaged and safe. But regardless of the architecture of the model, it's got to be consistent and reliable for patients to have that connection.
And I'm going to add that for a lot of patients who are on long-term cancer treatment, they really don't want to come every they have enough inpatient, they don't want to come every 2 weeks and spend half a day in the clinic. They are perfectly happy with the balance of convenience, giving them time back. Most of them work, they are parents, they have a lot of other things to do with their life. And if you give them that time back, but you still maintain the safety, the connection, and you see them once in a while, I think you create a much better balance than having them come every, few weeks to the clinic.
And then just one final point is, I think too, when we're implementing virtual care models, to have multiple channels and multiple types of virtual care and to be adaptable to the patient's preference. I mean, how powerful an exercise of gaining someone's trust is right at the onset of this experience for them. You ask them, what is your preferred method of communication? Phone call, text, asynchronous, video. If we honor that, we've started that trust building right from the get-go.
All right, here's a question from the audience. How is user error dealt with in remote care models? I assume they're talking about if a patient enters something incorrectly or is wearing a device improperly.
We will let the cardiology specialist answer.
Oh. Well, I better ask ChatGPT for a good answer. I would say that, again, it's people and process. And so one of the things that I'll just give an example of our nursing team. They are all nursing staff that we've trained in virtual care. So in our unit, our virtual care unit, we have 10 staff who consistently work in the practice to develop mastery, even though they're managing multiple populations because we've cross-trained them. But it's really the blend of the clinical mastery and technical mastery together. And so our philosophy has been, if you're engaged in virtual care, you need to have both skill sets together to a degree, unless it's something, code gray happens because there's a change with Microsoft Edge, or I don't know what, something that is not reasonable that we're going to tell our nurses to solve. Because I think that the management of those glitches for patients remotely needs to be fairly instantaneous to maintain trust and to carry on. And so it can be frustrating for patients where, they've got to talk to the vendor to solve a technical problem and talk to us for clinical. We did try that for a while, and what happened is we started having our patients call the vendor for clinical concerns and getting mixed up about who they're talking to. So I think it's parsimony around helping people remotely problem solve, and then they know who to contact and that our response is instant.
Yeah, just to build on that, the concept of patient education, I think, becomes ever more critical in a remote monitoring situation, where we have to start teaching patients how to convey this information to us. They come in an in-person clinic appointment and you can physically see some of those changes. We do need to think of patient education differently, and understand how do we effectively teach patients to be able to convey this information to us in a virtual manner.
I would 100% agree. We do quite a bit of education at the beginning of the care in the home. When the technology pack is installed, we have videos, and then kind of continuously throughout the process, because I think even though something may be intuitive today, in 2 weeks somebody may forget. And the other thing is the technology needs to be as user-friendly as possible. I showed the tablet and that the patients have in the home. I'm not kidding. The button, talk to my team, is this big. My oldest patient in the care at home is actually 98. He can barely see. He can see that button, and he knows exactly where to push and what to do. So we have to adapt the technology. We cannot do something that is extremely complicated.
So another one from the audience: how do we encourage clinical teams such as nurses to trust and adopt patient monitoring systems, spending the time to use them effectively rather than relying on traditional methods?
I'll go.
Good luck.
Yes, thank you. I mean, I don't think that we've necessarily cracked the nut on this one. I would say, when we're thinking of these type of remote care models, I think many of us immediately think it's going to allow us to do more with the same resources or more with less resources, and I'm sure every single one of us has written a business case to that effect. And I do believe that to be true in the long term, but I think we have to respect and honor that there is in fact a learning curve, and for these models to be successful, it does require an investment in staffing right from the get-go. I'm trying to avoid Keith's eye. Sorry, Keith. And I think that when we know that the clinical staff, the nursing staff in our examples are going to feel uncomfortable from the get-go, and we do need to just give them more space and time to be able to practice, and that requires an investment. And so it doesn't totally answer the question, but I do think being able to carve out time and not just throwing this new process on them is definitely at least a place where we need to start.
And I think it's also a learning curve, right, for everybody. I mean, I could see this in our command center chemotherapy nurses. Initially, they're like, okay, we're going to be online, and if something happens, I'm not even going to be able to do anything. I'm going to have to rely on the home health nurse to work with me to do something, even though as a chemo nurse, I'm trained to just jump. So that was the first thing, and then kind of as they went, right now they're actually innovating themselves. We just met with our nurse manager in the command center, and she said, I devised this system when one of my nurses can actually supervise 5 treatments, and guess what? When we're waiting for the nurse to come in the home, she can actually do a really quick visit for day 8 because she can just look at the lab. She knows the patient. So I think once they get comfortable with the system, you don't rush it on them. They get comfortable with this, they will just show you exactly like patient feedback, how to improve it. The nurses are giving us tremendous feedback on how to improve and make this more efficient.
I agree. I think we learn a ton from our nurses who are using this every day, things that we could improve. I think that initially for people who are new to it especially, you have to, earlier today there was a discussion around failure and conceptualizing that as part of success. You have to provide safe opportunities for failure to occur. And so one of the tactics we have used is user testing with simulated patients until our staff are comfortable with what they're doing. So the patients are remote, the connection's remote. We simulate all the problems so they feel comfortable not worrying about immediate consequence. Then when we're deploying for real and people, they're still learning to build speed and volume, it's about apprenticeship in the setting, having somebody who's familiar to help you problem solve, but then ultimately saying, at the end of the day, if tech fails, use your skills and talk to your patient, right? That is always there. People and process are first.
Are we too early days to get into nursing school and med schools? Do you think?
Not at all.
No, we're behind.
Behind.
It's actually an interesting point because you see, like in Ontario, we have Michener Institute has a new program, Digital Health and Data Analytics, and it's like all of these little education programs are popping up for the digital folks, for the tech folks, but where is that education for our clinicians and our care providers? I do think that we're behind on that.
Call to action. Okay. What should be done when elderly patients are uncomfortable with using a patient monitoring system, but their family members are pushing for its implementation?
Jen Bell. She's one of our ethicists. I think this probably ties back to the trust question as well. At the end of the day, I think patient preference really does have to rule your implementation of virtual care with a patient. I don't think, excuse me, I don't think that means that you don't have many conversations with the patient, making sure that you're showing them all of the different benefits, outlining as many supports as you can. But at the end of the day, the patient's preference has to be what you move forward with.
Yeah, I would agree, unless once you have a discussion with the caregiver and the family, and that caregiver can consistently be there to provide support and assistance to the patient, and the patient in the end becomes comfortable with this option, I don't think you should implement it if the patient says no. I do have one of my patients who's elderly, actually, her daughter is a physician. So after they've discussed, the patient became quite comfortable with, having this done if the daughter is there. I have another patient who's in an assisted living, and we're providing care in the assisted living facility, and the assisted living staff is actually there with the patient. So I think if you end up showing the patient that this can be done and they are comfortable with it, then yes, there are solutions to that, but only if the patient is agreeable.
It's an interesting question. With our surgical cohorts, including surgical oncology, I haven't seen that. So what I have seen is older patients wanting to use it, and then family members being concerned, am I going to be able to help? And the patient pushing for it. Other than that, it's been at the patient level saying, I don't want to do this, and we don't take it further.
All right. A conversation that I was having during the break and has come up here in a different form is basically there's been so many cool models, lots going on, lots of variations, lots of promise. Are there any concrete, consistent learnings to take away from all of this? Like what's the foundation of all of this work that people can take away about remote care?
For me, I would say that remote care is here to stay, I think. I think we can make use of those times in the cancer patient journey that doesn't necessarily require for them to be in a clinic or a hospital setting. I think we know we can do this safely we cannot compromise on quality. We have to deliver the same quality of care in the home like we deliver if they come to our chemotherapy unit. And the system and the care has to be cohesive, and it has to, the care team, it has to be under the supervision of a care team at all times. So it cannot be that the patients intermittently come in and out of the system and we don't know what happens in the home. So I think that's kind of my overall, I would say, thinking at least about where treatment, cancer-directed treatment in oncology will evolve. And then supportive care, I think, will explode even more because that is an untapped area right now. How do you minimize the times that the patients have to come to clinic for IV fluids, for IV antiemetics, for this type of low acuity, type of treatments?
This was brought up in this morning's keynote, but as you're implementing innovation, it is so critical to ensure that it is reducing work and not increasing work. The number of clicks matter. I like whoever answered that today. The number of clicks matter. And to not say, oh, this is going to reduce work in the future, I promise. If that is your answer, then invest in the resources up front, kind of coming from my earlier comment. And so that is an unquestionable learning, I think, for all of these. It has to reduce effort, or you have to invest in the resource.
Couldn't agree more. I think, as you both said, you have to have a process. The people in process have to be clear. If that's not clear, it's not going to work. There has to be a clear chain of command, how things are escalated up. It has to be resourced and well organized. It cannot be driven by the tech. It has to be driven by the problems you're trying to solve. And I think as we've discussed, there has to be a well-developed ecosystem in service to the model. And so how is inventory managed? How is it processed? How are all these things in play? And I think in the field, it's becoming time for a collection of best practices and lessons learned. As all these great centers are doing this work, it's time to share in a real way the mechanics of making it work. How do you really deal with those ground level issues and operationally?
Michael's response triggered me. Integration. To try and make the ecosystem as small as possible, don't have 15 different apps for the team that's actually using it, and don't have 15 different apps for your patients. Have it all as one to the greatest extent possible.
All right, I think this is a good one, but I might be botching it. So I'll just read it off the screen. How are you thinking about the potential bottleneck challenge in the future where patients actively choose to consolidate around the best remote care option and want the best doctor when they don't have the barrier of geography? So how might rural clinics and doctors be empowered to participate in this?
Well, I think rural clinics and doctors, need to participate because there is only that much drug that you can ship from Mayo Clinic, Florida to 300, 400 miles. I think you have to have the needs, local needs, right, of the patient being served. And actually the small clinics will be more empowered to participate if you find a way to have places where right now treatment cannot be administered, but subcutaneous nivolumab or other injections, et cetera, will allow those doctors to see more patients, and they will have the backup of a command center support of troubleshooting, chemotherapy nurses, et cetera. So I kind of see that the other way. Patients do want to stay local because they want to be around their families and they want to be around their lives. You just have to create, again, the quality of care that patients feel comfortable with receiving locally, and that can be done by using some of the remote resources that we have at the bigger centers.
Yeah, and I think it's considering virtual care not just as a physician or clinician to patient interaction, but a physician to physician interaction. So leverage virtual means and remote technologies to upskill and bring that specialized knowledge to the care teams. So you don't bring the patient to the specialized knowledge, you share the specialized knowledge out with those remote areas.
I think too, some of it is around organization of funding for innovation and research in the province. So for example, the way things are funded regionally, and there's 52 pilots happening, all for different little things. Innovation is great, but there needs to be a better system for recognizing maturity and discipline and scaling forward things that are at a state of readiness, while still allowing innovation to happen to inform those models as they evolve. And so, organizations like the Ontario Hospital Association looking at transformation, prioritizing where there has been rigorous track record of maturity and mistakes made and lessons learned is one way the public will be more aware of, how we can better standardize what we're doing.
All right, this one's around industry partners. So we can't do this alone. How can we engage industry partners, and who should we be engaging with?
What immediately came to my mind with this question was at UHN's relationship with Microsoft. We are a Microsoft Teams shop. It is what we use to deliver virtual care from a video perspective. And that partnership has been integral, and we kind of had to force ourselves on them. And so how do you partner with them? You be really loud and you advocate for yourself and you get yourself at the tables. One of sort of an interesting example is we were working to understand when we're delivering virtual care, how can we make it as accessible as possible? And one particular patient population we were looking at was folks who need American Sign Language translation. And what we had found was that Microsoft Teams at the time, I don't know if it's fixed yet, mirrored the image. And so you couldn't actually have an American Sign Language translator because it was backwards. And so it's little things like that where, of course, Microsoft isn't going to think about that. It's Microsoft. They're more of a business shop. They're not a clinical shop. And so it's us teaching them the importance of patient co-design, the importance of having a diverse patient population, inform your design, inform your testing, and things like that. And so I think it's the industry partners are the big guys, like the Microsofts, that their primary focus isn't healthcare. We need to be loud to remind them that, hey, you're being used a heck of a lot in healthcare, and so please listen to us. And you do build those relationships, even if it's through force at the beginning.
I would agree with that and want to amplify that the industry partners want to get in healthcare. They cannot fully because they don't have the clinical knowledge, the patient experience, the volumes of patients. So they cannot do it without us, and we do it a lot better with them. So I think if you really find that partnership, that is actually the way we can do it better together. Thinking about how do we bring cancer care in the communities, right? Every CVS has a minute clinic in US. I don't know if you're familiar with that. It's a clinic at the back of the shop, and then there are nurses there, nurse practitioners. Okay, can you deliver drugs in the minute clinic? Can you have patients being assessed there, or if they cannot, you cannot go to their homes, but they can come to the CVS. It's easier. So I think if you think about these opportunities on how to partner, there are many of those. You just have to identify the opportunity, the problem that you're trying to solve.
So I think your question leads to a number of tensions. If your relationship is coming through with a research-related origin before it's put into operations, I think a tried and true test for industry partners is how agile they are and how responsive they are to your needs. And so we've worked with very large vendors too, who are more in the device space, who lots of good intention, but cannot pivot quickly enough to to do what we need to do quickly to solve problems. Agile companies, often smaller, then there's trouble with how much capital they have to assist. And so you need both. And so I think with the larger companies, it's having that forceful voice. I totally agree. And then with the agile one, it's rewarding with opportunities in terms of being nimble and responsive. Again, though, back to the funding models and the way things happen, I find it challenging. You're trying to develop an ecosystem of innovation that translates into operations, and procurement rules get in the way of being able to work with different vendors for different solutions. And so we have to think about how procurement has implications for being creative.
All right, so most of this conversation has been implied or is specific to the adult population. What about pediatrics?
I would say pediatrics is a huge need, right? If you're asking whether there is need for treatment in the home or, remote monitoring, et cetera, but a lot of in pediatric cancer, for instance, right, there are many prolonged regimens that keep kids away from school, away from their families if they are hospitalized, et cetera. You have to recreate the kids' room with every hospitalization, right? Because they want to feel at home and feel comfortable. So I think there is a huge opportunity for us to do this in pediatric care, to do the treatment, to the supportive care. Now, we're trying to do this with Cancer Care Beyond Walls, and we're actually trying to partner with pediatric cancer clinics in Jacksonville. There is a big barrier that I did not know. There are not a lot of nurses, home health nurses, that actually are, and I see some people nodding their heads, they probably know this from a nursing perspective, that are comfortable or trained to do pediatric care. So in Jacksonville, I think we've identified 2 or 3 nurses in the home health agency that we're working with, which is huge, that would be comfortable doing pediatric care. So you have to solve this problem. You cannot leave anybody behind, right? You cannot leave rural folks behind. You cannot leave, population that needs behind. So is this now a training opportunity? Is this a staffing model opportunity? How are we gonna handle with that? But it's a little bit more complicated than I initially thought. I said, wow, this is great. Let's do it for all kids in the home. And it's not quite that easy.
I don't work with pediatric patients, not since 30 years ago when I worked in Texas. So, but I'll just give a shout out to our adult surgical patients' children who are extremely engaged and helpful all the time.
All right, this one's coming from our friends from Saskatchewan. Sounds like they've cracked it and have been doing this for providing systemic therapy for patients in remote areas for over a decade. And they are wondering how they can share their experiences. I don't know.
Publish it. If, models that are published out there, I think are the best. We look at, initially when we started our Cancer Care Beyond Walls program, there is not a lot. There was a little bit of information from UPenn as they did this during the pandemic. And then most of the information we found from smaller studies published from Europe. Smaller or larger, but that was, such great information. And then we saw something in UK, for instance, where they have a chemo bus, which is my dream at some point to have this at Mayo, where this bus actually has 1 or 2 nurses and 2 chairs or beds where patients can be treated, and they go all around all the remote areas and they treat patients with chemotherapy, and they have the ability to also, they're better equipped to handle with some emergencies as well. So as you read about this, ideas spark, and then you can continue to build on them, and we need to collectively make the case so we get reimbursement for this model of care, because it doesn't matter where you treat the patient, it matters how you treat the patient, right? Paclitaxel is the same here or in the hallway for my patient, right? So I think that's the case that we have to make.
I do think there's a role to play in communities of practice as well. In Ontario, in the pandemic, very quickly there was a virtual care community of practice that was stood up, and it was pretty much all of the centers across Ontario. We would meet monthly and just talk about what was working, what wasn't working, and just sharing, and it was so effective. And then it created the network. You had mentioned advocacy. When there were changes to the remuneration structure of virtual care, we already had that network where we could band together and have advocacy sent on a group level into the ministry. So it's a very simple solution that we've had since the dawn of time, but in my personal experience, communities of practice are still exceptionally helpful.
Would love it if you're willing to give a talk online even and hear all about your experience. That would be great. Wonderful learning for us at the JCC.
All right, maybe one last one to close it out. So on an optimistic note, futuristic note, beyond the chemo bus, what is the next frontier of remote monitoring? What's big, bold, what's the future, and how do we get there faster?
I mean, how we get there faster is through partnerships. To build on the last conversation, I think it's unquestionable that virtual care right now is happening in little mushrooms, and we probably aren't sharing enough. And so as a collective, we do need to figure out, and I think you made a really great point too, just from a policy perspective, how do we define when something is now a proven model that should just be shared broadly? That didn't answer the frontier question, but I wanted to jump.
I would say, in the United States, the next frontier is to be able to practice across and treat across state lines, right? So, and then to have a reimbursement, a reimbursement model for this. And there is a question up there: if it's so promising and it's lowering the cost, why is it not moving faster? It's not moving faster because there are pockets of who gets the reimbursement from the drug. Right now, the drug cost is what drives oncology practices, at least in US. And that's very difficult to, I think, let go of, or and everybody's scared that if a new model comes, then how is that going to evolve? And I think that's why it's not moving faster, honestly. So once, we have a model of reimbursement that's equal, I think, and be able to practice across state lines and make this a model that is shared across all of us that practice in oncology or in cardiology, then that's how it's going to move faster.
Yeah, I agree. I think we have to get beyond reimbursement per procedure, per task. We have to look at expansion of value-based care models to be able to facilitate scale and break down geographic barriers to how this is going to work, and work together to develop systems of, what programs are mature, what can be adopted, how can we work together so that there's recognition for innovation, but there's also sharing, so that, there's a healthy level of competition, but not such that groups are doing things in parallel and not talking to one another.
And I think we've underutilized the patient voice in our own designs, in our advocacy. I got so many ideas from Nick in just the short time that I heard him speak earlier today. And it's one of my favorite sort of leadership theories, and there's a very funny video online, is the concept of the leader, and then you have the first follower, and then after you have the first follower, it just snowballs from there. And I feel like from a patient voice perspective in virtual care, we're still at the leader perspective. Like we have the Nicks of the world, and you can all think of that one patient that's like really gung-ho about virtual care. You probably have the exact same patient on every single patient family advisory board. We don't have those first followers yet, and I think that we really need to be doing more to focus on getting those first followers so that when the patient voice becomes so loud that the government can no longer ignore us. And so I definitely think we're underutilizing that patient voice.
Awesome. All right, well, I think this is a good place to end it. Thank you all very much.
Thanks for having us.